So we went from the brain to the heart, and we're going back to the brain. And our next speaker needs no introduction. Dr. Eli Diamond, the diamond shines from far away. And he's a dear friend, a neuro-oncologist at MSKCC in New York, a lead care center physician. He's also he's the chair of the ECDGA Medical Advisory Board and a past recipient of ECDGA grant. And he's going to talk about the effects of ECD on the brain.
Thank you for having me. I look forward to this event all year, so it's really a pleasure to be here. It's nice to come after the heart. We neurologists like to say that the purpose of the heart is to give blood to the brain. So I'm going to talk a bit, mostly about the brain, a little bit about the eyes, sort of the spectrum of effects of ECD on the brain, and sort of some principles about treating ECD in the brain. Can I take this? Maybe easier because I'm cocking my neck here. So in my registry study, if you look at how patients report symptoms, about 3/4 of the ECD patients in my cohort report neurologic symptoms of some kind. If you do that by scans, it's probably more like maybe 1/3. Depends on whether you're talking about the substance of the brain itself or sort of contact with the brain. I think that there's an abundance of neurologic symptoms and issues that are really not explained by scans, and you probably need to hear that, not more than anyone else does. And about half of ECD patients have some kind of abnormality in the eye if you look hard enough, and then these treatments can affect the eyes. So this is just a few MRI scans of different manifestations of ECD, I'll say lesions or tumors in the lower part of the brain. Is there a pointer here?
Pointer should be there. Do you see a button?
Nope, sorry.
It should be this is it, I think.
Thank you, sorry.
The white button.
Okay. Yeah, so this is the lower part of the brain. This is the cerebellum and what's called the brainstem. And so this is what coordinates movement of the eyes, the arms, and the legs, sort of posture stability and walking. So sort of the classic, typical symptoms of ECD in the brain are decrease in the speed and the clarity of speech. Sort of starts like maybe someone feels like they have one marble in their mouth, and then that can get worse. Imbalance caused by instability of the trunk, and then sometimes the arms and the legs, decreased coordination, and then potentially weakness or stiffness of the arms or legs. And then if this is more severe, there can be issues with swallowing. This part of the brain, while it coordinates the arms and legs, one of its more kind of unsung functions is sort of regulating mood and also regulating the way that we manifest our mood. So some people with ECD involvement of the brain they can be a little giggly, or they can be a little bit easily emotional, sort of easily tearful, sentimental. They may not always feel as emotional as they look. So these are the kinds of things that can be distressing to onlookers, but I think if everyone understands what they are, it can kind of disarm the feelings about this. Apart from this back part of the brain, ECD can involve the pituitary and the hormone system. So DI, or what's now called AVP deficiency, can be fairly common. And then affected individuals can have loss of other types of hormones, including sex hormones, and have infertility. ECD can sometimes grow on the lining of the brain, called the meninges, and cause different growth and different symptoms depending on where they are. And then in terms of the upper part of the brain, not the lining, something like this I've seen, but is fairly uncommon, and the symptoms would be kind of referable to where in the brain that happens to be. There's just an array of issues that people have that, it's kind of where does the brain end and where does the psyche begin? I don't think we really know. So, fatigue is just plaguingly common for patients with ECD, things like brain fog, and then issues with worry and depression. We did a study about this in our registry that 1/3 of patients with histiocytosis generally have anxiety or depression, and then 1 in 7, that's moderate or severe. And then depression is actually most common in ECD and is associated with having neurologic involvement of disease. Cognitive issues are, I think, very common and under-recognized. Things like difficulty paying attention, remembering things, multitasking, ability to work can be affected. We just had an article recently showing the high frequency of unemployment in patients with histiocytosis. And then this can be people with normal scans. So having a normal scan does not mean that you are not entitled to this whole array of issues and problems that could be sort of related to or associated with your ECD. And as I mentioned, this is the most common sort of constellation reported in our studies. So this, I say this not to upset or alarm you, but hopefully to validate some of your experiences. We looked at sort of advanced sort of quantifying volumes of the brain. This is a long time ago, comparing ECD patients to normal controls. And the ECD patients were people with normal brain MRIs. So not ECD tumors, not lesions. This is a scan that the radiologist looked at and said, this is normal. And there were some areas of shrinkage of the brain, sort of throughout the brain. The color coding is not a measure of the severity as much as it is the statistical significance. So it's statistically meaningful, but not dramatic, because again, these brains are normal to a radiologist, but there is something happening that is submerged within what we can see. And then this is just an array of different manifestations of ECD in the eyes, either around the eyes or on the surface of the eye. This is the back of the eye called the choroid, behind the eye, all different ways that if you look hard enough, you may find different hints of ECD in the eye structures. So, what I call the conventional therapy, sort of chemotherapy, interferon, all the stuff that's not the targeted treatments, I think that these have kind of been eclipsed with the current targeted therapy era. And I don't have a ton of experience with these, except to say that they can be great, but not reliably so. So I think we all have cases of ECD in the brain that had absolutely phenomenal responses to some of these older treatments, whether it's cladribine, chemotherapy, methotrexate, interferon, but an abundance of examples where it did not do very much. So I think that we kind of back into these when we need, but we don't reach for these first anymore. And then for targeted therapies, there's very much a sort of glass half full, glass half empty. This is a incredible disappearance of a brain ECD lesion on a BRAF inhibitor, similar here and similar here. And so some patients and some brains have incredible outcomes with these. And then, there's also some hitches. This is one patient who went on a treatment, everything resolved, but then he had to stop the vemurafenib or the zelboraf, and then the stuff comes back. So there's a little bit of a push-pull of you suppress the disease as much as you can, but then it comes back if you stop it. And then also there is this other phenomenon of some patients arrive at a dose that is most tolerable, sort of in the big picture, side effects, what have you, and then sometimes there can be like a little bit of a creep of neurologic symptoms that maybe they weren't even there before, a little bit of balance, a little bit of speech. And so this is someone who, you can see these little white dots here that weren't there before. This is on treatment, but on a very low dose of zelboraf, which was kind of what his body needed for overall symptoms and side effects. And so, I have some patients who get a low dose and everything goes like phenomenally. And then some people, whether they just don't tolerate it or their brain needs more treatment. So there's really quite a spectrum of sort of like the best case scenario where everything is suppressed completely in a way that's lasting, or this sort of push-pull of trying to optimize treatment, change the medicine, optimize side effects, and try to sort of iterate and get as much a treatment as we can. And there are some new brain-penetrating treatments that I'll mention briefly. So I don't know what's best. I think that I have a very individualized approach. I have as many different treatment plans as I have patients, whether people do high dose for a few days and then they stop, or they do low dose. It's the kind of thing that I get to know people over time, and it may take many visits, many tries. Someone may be on their 15th sort of combination until it gets to be the best for their brain and their overall balance and quality of life. So I'll just mention two outside of the box things that we've worked on. So this was borrowed from eye tumors in children, so quite different, where a proceduralist, as though you're going to go to the heart like to get a stent, they go further and they inject a little bit of chemotherapy right behind the eye, right behind the brain. And so this is kind of a map of someone's tumor, and we map the blood vessels, and then we sort of decide what blood vessels and what dose of like a little bit of chemotherapy is going to be given. And so this is an ECD brain that was treated with this sort of injection of chemotherapy, and there was a very nice improvement in the scan, and then actually a resolution of her double vision, which was coming from that area in the brain. And then just similarly, someone else with this sort of really hideous eye tumor here with the eye bulging, sort of really improving and resolving with this intra-arterial treatment. So this is, it takes a specialized center. I know that some of my colleagues here have been administering this as well. It's really a very sort of patient-specific, circumstance-specific type consideration. And then I just want to mention there's a new MEK inhibitor. There's COBE and trametinib and all the others. This is a more brain penetrant, in theory, as much as is in your blood gets into your brain. I've had the benefit of being able to give this to a handful of patients whose brains have not done well enough on COBE, Zelboraf, et cetera. And so this is a pituitary tumor here that grew on cobimetinib that improved on this brain penetrant version. So a few cases that are sort of very good proof of concept that if you can get a brain penetrating agent, you can get a little bit more benefit. And we have a trial of this drug going on now that we'll talk about later. And then this is just the same for that brain penetrant drug, just different ways of trying to measure if it works, because scans don't always improve. So we can sort of quantify people's balance, put a number on that. If some people have issues with vision, we can measure if their vision improves or if their hearing improves. And we've seen instances of all of these. So in summary, it's a tough manifestation of ECD, and it's tougher than you'd even think from the scans, which are tough themselves. And I think there's this kind of tangle of delayed diagnosis, symptoms that last a long time, fatigue, and fatigue can make neurologic symptoms worse, and then you sort of add the mood struggles on top of it, and it's very hard to break the cycle. The current treatments have definitely helped, but they have their limitations, and we'll all benefit from some new approaches. And I'll leave it at that. Thanks.